All right, here we go. Um, so something we talked about briefly yesterday was the left versus the right hemispheric stroke. Um, the main difference I'm just going to draw your attention to is that when you have infarcts of the left hemisphere, you're going to have profound language deficits and cognitive deficits. Uh, the left hemisphere, regardless of what your primary writing hand is, often still considered the dominant lobe, and uh, any large infarct in the left hemisphere is going to leave you pretty disabled, and you're going to require constant nursing care more than likely. Um, Now, everything else, like you can see over here on the right hemispheric stroke, you see left-sided weakness, vision changes, impulsivity, decreased attention, judgment, neglect. You can see any number of these deficits on either side. The things that you want to remember is that you're going to have profound language and cognitive deficits when it comes to left hemispheric strokes. And remember the symptoms that we talked about. The primary stroke symptoms that we talked about in the previous slides being that you have contralateral weakness of arm and leg, tongue deviation, visual deficits, sensory deficits, motor deficits. So jumping down, here's a good picture of a tool that we use for assessing the patients who come in with stroke, or we're trying to assess for signs of stroke, called the NIH. So this is the National Institute of Health Stroke Scale. It's common practice within institutions, and it is an actual certification that you can take. I want to say it's like $5 or $10. It's not much. But it is a comprehensive look at your patient's cognitive, motor, visual deficits, sensory deficits, as well as things like limb ataxia, dysarthria, and extinction or inattention. So I'm going to run through this quickly. Question on the board: is our left strokes more common than right strokes? I actually don't know. I don't know what the numbers are on that. So the NIH has its usefulness, but it also has its limitations when it comes to complex presentations. So, oh, the camera thing popped up. So we'll start at the top and run through it real quick. So 1A is level of consciousness, and you can see that there's a scoring tool on the side. So if you have a 0, that's great, that's perfect. We all have zeros. But if you're upwards of, even if you have a score of 4 or 5, you're concerned that their stroke is present. If you have a score of above 20 and or even higher, your chance of mortality becomes very high, as well as permanent disability. So you can see at 1A, we have level of consciousness, and that goes 0 to 3, and you have alert, drowsy, stuporous, coma. Now, one thing I will say, and it's not something you see on the sheet, but these sheets typically come with a second page that has, like a 3 or 4 sentence blurb on how to interpret some of the things that you might see and how to score a patient if they fall outside of these bounds. For instance, in some of these, you'll see like untestable for a joint fusion or a limb amputation. Now, untestable scores, or not being able to test a category, is only under very specific circumstances, like you can see in 5A, 5B, 6A, 6B, that it says untestable due to joint fusion. These are some of the only cases in which something is untestable. They try to account for things like intubated, like this. But even now, there are guidelines for how to try and interpret, and they will give you a set of circumstances, like if your patient is obtunded or X, you'll have to assign a score based off of what you see. So that can be where things get really tricky, especially in severe strokes, where patients have a high degree of difficulty participating in the exam. So level of consciousness, you have LOC questions. Typically, you can suss this out during the course of conversation. Commands, can they make a fist? Can they, they typically want to see if they can follow two sequential commands. Excuse me. Um, excuse me again. Now, one thing that can become tricky is to assess whether a patient is truly following commands because you have reflexive movements that the patient will do. For instance, if a patient squeezes your hand, that is not indicative that a patient is following commands. It is if the patient can release your hand on command that they are following commands. To grasp is a reflexive motion. So sometimes it becomes very difficult to tell if a patient is just localizing and interacting with what's around them versus if they truly understand. Um, Thank you, Chelsea. Um, Best gaze. So here we're looking for gaze palsy, which is a common symptom you see in these large hemispheric strokes. Gaze palsy meaning that the patient cannot look in a certain direction. And even you can see on the score, you have normal, partial gaze palsy, or forced deviation. Forced deviation meaning that when they've had this stroke, their gaze has deviated in a certain direction and doesn't move from that direction. It is not uncommon at all to see a gaze palsy and forced deviation in the setting of a severe stroke. To do this, you want to try and to assess this, you want to try and get your patient to track your finger and see if they can cross midline to the other side, or see if they stop midline, or if they'll track your finger at all. Visual fields here, we're looking for signs of hemianopia, meaning loss of a visual field. When you have a large MCA stroke, it's very common to lose the entirety of one half of both of your visual fields. When you think of an individual eyeball and what it sees, you can separate that typically into 4 quadrants. So it's very common that in MCA strokes, your patients will lose half of the visual field in each eye. So it's usually a top and a bottom quadrant. And you can look in it, which I can see if I can pull it up for you. There's kind of a complicated visual pathway, which will show you, kind of give you an idea of where within a pathway, if a lesion or let's say a stroke occurs, how it can affect your vision. But the most common presentation that you're going to see in a stroke is something called a hemianopia, and more specifically, a homonymous hemianopia. Don't even try to spell it. It's awful. Which means you're going to have this bilateral loss of one half of your visual field. Facial paresis, so you're going to see drooping of the face. Now, drooping of the face is not always inclusive of the entirety of one side of the face. It can be the top, it can be the bottom, or it can be both. You can see 5A through 6B looks at motor control of arms and legs, and this is typically where we say, hold your arm up, close your eyes, and we'll count to 10 and see if the arm drifts, if it falls to the bed, if they can even get it off the bed, and when their eyes are closed, if they can keep it positioned in space. Same thing goes for the legs. Limb ataxia, we can do finger to nose with the upper extremities, and then we can do heel to shin, which we discussed. Even in a normal person, might not be that easy. I can tell you, I'm not good at it. Sensory, we're going to do 2-point distinction here. So we're going to do, can you differentiate between sides just on touching? And then we're going to use sharp and dull. Dysarthria is we're looking for signs of, I skipped 9, best language. So this is looking for signs of aphasia. Are they able to speak? Are they able to express and understand, or are they mute? Dysarthria, looking for signs of slurred speech if they are able to speak. With dysarthria in the setting of having a stroke is very common. If your patient is dysarthric, they more than likely need a speech therapy evaluation because they have some dysynchrony or muscle weakness of pharyngeal or upper airway muscles. And then finally, we see extinction or inattention, which honestly, this is kind of hard to tell. Extinction or inattention is when a patient to some degree ignores one side of their body, which is typically the contralateral side to the stroke. Now, to assess some of the stuff, you're going to have to look at the patient closely. And some things that you can do are, trying to approach the patient from that side, trying to notice if they look at you. Ask them if, and again, this goes back to what we said earlier, ask them if they can move that side. If they say no, show it to them. And sometimes they'll be able to move it. And that's another sign of extinction or inattention to a side. So things to take away on this is all of these categories are testable and they need to be tested. That's the only way you can get a true NIH score and tell you where the patient's at. So here we can see this is a type of stent retriever that is similar to what they use for clot removal. So you can see over here that they're deploying the stent, and there's a little clot, which actually looks almost like atherosclerosis there, and they can typically go in and grab these. Now what you'll find is that whenever they have to snake one of these up to try and snag a clot, they have to do it several times, and one of the unfortunate side effects that can happen is that they can pierce the vessel, which is, I would say, is relatively uncommon. I don't see it that often, and even if they pierce a vessel, that doesn't mean that they're going to have this huge hemorrhagic conversion. Often they just have a little bit of extravasation of blood and contrast into the tissue, which we can see. But sometimes they can also break this clot up and send it downstream, which is awful because sometimes it goes so far down they can't get it. So a patient can have a worsening stroke than they had before, or a multifocal stroke. So we talked a little bit about TPA, but this is alteplase. This is your thrombolytic to try and break that clot up. You have a 4.5-hour window from your last known normal, which is extremely important to establish when a patient comes in. When were they last seen normal? We need to rule out any risk for bleeding or contraindications. We're going to do that head CT to make sure there's no blood in their head already, to make sure they didn't have a hemorrhagic stroke. No head trauma surgery or previous stroke within 3 months, and dosage is weight-based. It's 0.9 milligrams per kilogram with a max dose of 90 milligrams, and 10% of the dose being given in a bolus over 1 minute and the remainder of the dose over an hour. You do not need to remember that. Major side effects of this drug is bleeding. You want to avoid any unnecessary IV sticks, any catheter insertions. If your patient's gone for a thrombectomy and they've had their groin site accessed, then you're going to need to watch for any bleeding and take extreme care when handling the groin site. Patients who come in and get TPA in our institution are going to be a one-to-one for at least 8 hours, because they at points require Q 15-minute neuro checks, because these patients' neurostatus can both change frequently, but also they're at a 6% risk for having a hemorrhagic conversion. You're going to spend at least 24 hours in the neuro ICU. And then at the 24-hour mark, you're going to have a repeat head CT to make sure that you're still stable. Controlling blood pressure is a big issue, and in TPA, you want to keep these patients typically less than 185 over 110. And you need to be, that is a quality measure that is checked and monitored by our certifying bodies. So you have to be active in controlling blood pressure for that reason, but also too, if your patient is grossly hypertensive and they've received a thrombolytic and they're at a high risk for having a hemorrhagic conversion, having high blood pressure doesn't make that any better. So in these patients, you're going to monitor their neuro exams extremely close. In the best of worlds, they're going to start to improve. And it's actually really cool to see that happen when a patient who couldn't move an arm or had a facial droop, you can see that resolve in real time. But sometimes you can have a patient who has a suddenly worse exam, which can include a headache, nausea, vomiting, decreased LOC. So you have a very low low ceiling for getting another CT to make sure that they're not bleeding, because once they start to bleed, they may need immediate surgical intervention to decompress or evacuate. But if they've been given TPA and they begin to bleed, they're not getting surgery. So um, mm, 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 mm. Jumping down to medications, we're going to try and pick up the pace a little bit because we still have a fair amount to cover. Other medications that you're going to see, aspirin. Patients come in with strokes are going to get an aspirin. This is suppresses platelet aggregation. They give it to TIAs and strokes. It does reduce the risk of recurrent strokes. It says the effects last 7 to 10 days, and I know traditionally, you'll say, like, oh, well, this is not your system. You can't have surgery or what have you. But aspirin effects is the effect of aspirin is actually a little controversial right now because there is some evidence saying that maybe it doesn't have that profound of an effect, but for now it's still part of the stroke pathway. Plavix is another that suppresses platelet aggregation. It has a less of a risk for ICH and GI bleeding. I think that some of these drugs get a little bit of a bad rap because traditionally we've thought, even for things like Lovenox and subcutaneous heparin, the traditional thought has been, oh, if a patient has blood in their head, they can't have this, which isn't at all the case. We typically start people on things like oh, I lost my train of thought. So typically think that things like Lovenox can cause worsening bleeding. Often after 24 hours is not the case. We like to start VTE prophylaxis early. You're going to see Plavix most often in cases where patients may have had to have a stent placed because that stent needs to stay patent until the body builds a little protective barrier around it. And you'll see it in some patients who have stroke as well. Anti-seizure medicines may be prescribed, but it's kind of uncommon unless the neurologist sees a specific problem that warrants it. Dexamethasone is not often used in stroke because of the swelling. The type of edema that occurs in stroke often is not responsive to steroids, but in cases of, let's say you have vasogenic edema from a tumor, dexamethasone is actually really good at crossing the blood-brain barrier and is the steroid of choice when we're dealing with things like intracerebral or intracranial vasogenic edema. It can be given PO or IV, and the side effect profile is similar to glucocorticoids. I know we mentioned it, I think, in our respiratory module. And you're going to want to start checking blood sugars because their blood sugar goes up and blood glucose management decreases mortality and is also a quality measure for the stroke pathway. Tylenol is one we're also going to see commonly. Used for fever prevention. Be proactive about managing your fever. It says here that fever burns brain, but speaking more pragmatically, being febrile burns a lot of oxygen, and oxygen is going to be a precious resource in a brain that's damaged. So you want to be very proactive about managing central fevers and also trying to assess for if a patient is febrile, is this coming from the brain or is this coming from an infectious cause, as patients who have stroke are very prone to getting things like aspiration pneumonia, and making sure that you're not exceeding 4 grams per day. So let's jump over to stents real quick. So in the case that you have a patient who's dealing with like stroke secondary to carotid stenosis, they may either undergo a angioplasty or a carotid endarterectomy, or CEA. This is a procedure in which they dissect out the carotid artery, and you can see it in this picture, and they remove the plaque and clean out that vessel. So your role in nursing, it's in the post-op care of these patients, is going to be focused around a couple things. One of them is making sure that their airway stays patent. There's always a chance that where they were working can begin to bleed, and that blood, given that it's from the carotid artery, can compile fast and compress your airway. Also, just general swelling and edema post-operatively. So have a low ceiling for keeping these patients in PO if they're having difficulty swallowing until they can be seen by a speech therapist. You can develop a thrombus formation in that area, which is why we anticoagulate these people early. So, we're going to want to do neuro exams, make sure everything's intact, and make sure if they were already having neuro deficits, that these deficits are in line with what you saw at baseline. Also, another practical thing that no one ever seems to mention is that you can measure their neck, and I actually highly recommend it, because if you have any signs, if you have any concern that your patient is bleeding into their neck, it helps to have a little piece of objective data to help substantiate that. Hypertension can be a problem. Oftentimes they want these patients at a very specific blood pressure. It's not at all uncommon that these patients come up and they say, keep them between 130 and 150. Reason being, one, we want to maintain perfusion because the body has become acclimated to a certain level of perfusion, one. And two, now that we've opened up that vessel, your brain is at risk for developing reperfusion injury, which can be devastating. So you want to try to avoid that. Keep in mind so there's a note here on the slide that says hypotension, reduced perfusion. If your patient is used to living at a certain blood pressure, keep in mind that if they develop new neuro symptoms, that it could be from their blood pressure. Sometimes they might need a little bit more blood pressure to adequately perfuse their brain, and this is not that uncommon, especially in patients who are chronically, jumping back over to ischemic stroke, patients that are chronically hypertensive, like 180, 190, 200, they have a stroke, and we go, oh my goodness, and drop their blood pressure when they come in, and now all of a sudden they have much worse symptoms. Keep in mind that they might need higher blood pressure. I'm not going to do the case studies. So this is one thing I want to talk about is door to needle. So this is part of the quality measures, and you'll see this with stroke, but you'll also see this in MI to make sure that these patients are getting in quick. We want to have the most streamlined process to get these patients in, examined, so seen by a doctor. They should be seen by a doc within 10 minutes. Their stroke team should be aware that they're coming and should be, on site or available by teleconsult to see these patients and in the scanner. Here it says less than 25 minutes to get them into the scanner, but honestly, we want them there. We want to try and get them, like, they're going to come in, the doctor's going to look at them, they're going to get weighed, and they're going to go straight to the scanner. We want them getting out to place hopefully within an hour, if not sooner. And if they don't do that, they have to do like a little write-up as to why this didn't happen. And we do get penalized for that. Let's see. I'm just going to jump through a couple of these. So let's jump down to complications. So one thing that can happen, a major problem immediately after a stroke occurs, is that you can develop malignant cerebral edema. So just like any other tissue, just like any other tissue, when it becomes damaged by lack of oxygen, it can begin to swell. Now, like we talked about yesterday, that brain is in a fixed compartment. So if that brain begins to swell, it doesn't have a lot of room to compensate. And one of the things that we look at in the acute phase, the hyperacute phase of the stroke, when we're looking at a patient's CT scan, is to see how much room do they have in their brain. Given that strokes typically happen in older individuals, and cortical atrophy is a normal part of aging, one of the things we will look at is how much room do they have to swell. Because just be, we've had the stroke, which is a devastating neurological event alone, but once that brain begins to swell, you have this increased ICP and you can herniate. So we'll try and intervene as we can to keep that from happening. Now with strokes, you have about a 3 to 5 day window where swelling can occur. Hopefully that's going to peak around day 3 to 4. So you got to keep a close eye on these people. Now, it becomes fairly clear early in the course of treatment if this patient's going to swell, because they tend to get quite a few scans, especially if they have any form of neurological deterioration at all. So we're going to be checking them frequently. Other complications are cardiac arrhythmias. I'm actually going to shoot that to the top because you can have neurogenic cardiac issues. It's not terribly uncommon that these patients develop NSTEMIs just from the stress of the event. Obviously, we're going to have issues related to immobility, i.e. pressure ulcers. Patients can develop contractures over time from disabled limbs. Patients who have balance or gait issues from weakness or other can have falls, can have secondary injuries. You can have CAUTIs secondary to Foleys that exist, or patients who require frequent straight caths because of urinary retention. So these patients can not only do we deal with this immediate devastating event, but it can have very profound long-term implications, which can leave them requiring a high level of care. Aspiration pneumonia is a big risk. These patients, especially the ones that are dysarthric, have a low threshold to keep them in PO. These patients can aspirate and show no signs of it at all, which is what you call silent aspiration, right? You'll find now that I know when I first started nursing, we did not have a lot of options as far as diets were concerned. But now we have all kinds, mechanical soft chop, mince, pureed, honey thick, nectar thick. So they have options. And a lot of times they're going to have a decreased appetite anyway, so they may need tube feeding to supplement as well. And also you're going to need to work with speech pathology and the dietitian to try and figure out a plan if they're not taking in adequate calories. Sometimes, we have family bring in stuff from home that's consistent with things that they can eat, and oftentimes we'll work with the dietitian to figure out what those things are. But we often do put feeding tubes in these patients just so we can start some nutrition going down to try and keep them fed. So, and a big final phase of their care is rehabilitation. Rehabilitation should start immediately. Typically, when patients are admitted, they immediately get a consult to physical therapy, occupational therapy, and speech therapy. We want to get them moving early. We want to get them out of bed early. We want to try and decrease their chance of having forming a clot from immobility. We want to get everything moving. The faster patients get moving, the faster they get better. I'm not going to get super heavy into the rehab part. We're going to jump down to hemorrhagic strokes, and there is actually a link in here to this TED Talk, which is actually really good. It's called My Stroke of Insight. So if you have a chance, you should watch it, but we're not going to go over it now because we're short on time. We're going to jump down to the intracerebral hemorrhage. Now, the hemorrhagic stroke and the ICH, or the intracerebral hemorrhage, they're fairly synonymous terms. This is when obviously you bleed into your brain tissue secondary to the rupture of a vessel. Now, the one difference you will find between these is that typically, like an average hemorrhagic stroke happens somewhere in a vascular distribution, meaning that somewhere, say, along the MCA distribution and where that goes, or maybe the ACA, versus a general ICH happening in deep brain. Do not get caught up on trying to split the terminology because it's a rabbit hole. So one of the things that we talked about yesterday was deep brain structures, right? So basal ganglia, thalamus, things like that. You can actually see here on this top photo, this is the CT. And the right side, you have a rather large ICH, which actually looks like it's outside of deep brain. If you look, let's look on the left side here, and if you can appreciate this dark area, this is your thalamus. So it looks like you have your thalamus right around here, and then you'd have your caudate and your putamen and your globus pallidus would be in this zone. So this looks like it's occurred probably along the MCA territory distribution. There's controversial evidence about the efficacy of evacuating hematomas from ICH. As of right now, there's no true data to support that it has a benefit. Mortalities in ICH can be high, but you can also have people who, let's say, have some sort of vasculopathy, like a amyloid type. They can have recurrent small hemorrhages, which their symptomatic manifestation can vary widely, from I just have a headache to I am in coma. But one thing to remember is that blood in the head causes increased ICP, right? Because we have that fixed volume. If we introduce a lot more blood into it, we have to make room for other things. And even jumping back over to the CT, you can see one, complete effacement of the right ventricle, which is this little slat here. And you can compare that to the left ventricle, which is the slat here. And you can see that all these structures have been moved pretty far away from midline. So this patient is experiencing some form of subfalcine herniation. So if they are in danger, they may require a evacuation anyway, just to get pressure off of the brain and potential decompression. These bleeds in the head are often related to hypertension. So you tend to see these patients come in and their blood pressure is well over 200, but can also happen secondary to large aneurysm rupture and AVM, which is arteriovenous malformations, or a tangling of arteries and veins that have grown inappropriately within the brain. See, I think we talked a little bit about LPs already. Let me jump back to ICH real quick. So treating these patients, you want to, one, not make it any worse, right? And two, treat the underlying cause. So we're going to do a lot of blood pressure control, making sure if they have an unsecured, if they have a bleed, it could be anywhere between 140 to 160, keeping them below that mark. If it's an aneurysmal in nature or a large bleed, it's typically going to be less than 140. These patients may go for an evacuation, but like we said, there's no mortality benefit to an evacuation, but they may do it just because it's taking up too much space in the brain and they have to relieve some pressure. They may insert a EVD or an external ventricular drain to help drain some pressure off and or monitor. And then we're going to wait. The hope is that these patients will have a recovery. There's a common misnomer that patients who have these large bleeds now have a lot of dead tissue in their brain, which often may not be the case. I will say that even though in certain cases mortality can be very high, you can also have patients with devastating bleeds that get better. So, and that really depends on assessing that. It really depends on the ability, one, of the patient, two, a little bit of chance, and three, the neurologist's assessment and how they choose to treat. So we're going to jump down to subarachnoid hemorrhage. Subarachnoid hemorrhage is another form of intracranial bleeding. This occurs within the subarachnoid space. And reviewing our A&P from yesterday, we talked about those meningeal layers, right? So we have the dura mater, the arachnoid mater, and the pia mater, but there is a space between the arachnoid mater and the pia mater, which is the subarachnoid space. So CSF circulates in that space as well as where your vessels run. Unfortunately, you can develop aneurysms on those vessels and they can rupture. There are several types of aneurysms. We're not going to go down that rabbit hole right now, but they typically form at the bifurcations of vessels where blood hits the wall of the vessel and is directed in another direction. So patients can have a genetic predisposition to this. They can develop from smoking. They can develop from meth, because meth has a specific effect on certain layers of the vessel, which can cause these aneurysms to form. But subarachnoid hemorrhage happens when this aneurysm ruptures and blood spills into the subarachnoid space. This can be devastating and can have an extremely high mortality. So when these patients come in, they're often scored using two methods. One is a Hunt and Hess, and the other is a modified Fisher. These are based on their presentation, meaning do they come in with just a headache or are they in coma? And there is a scale in there. And two is measuring the amount of blood in their head. Now, the more severe their presentation, the worse their mortality is. If they have a high Hunt and Hess score, their mortality can be as high as like 97%. Because what can happen is all this blood, especially if it's from a large aneurysm, can fill all these spaces in your brain, can cause your vessels to spasm closed, and just from the sheer pressure can stop the circulation from getting into your brain, so you can have infarction as well. You can also develop hydrocephalus because the blood blocks up those arachnoid villi that we talked about and stops CSF reabsorption. Now, it mentions here intraventricular hemorrhage. I don't want this to be categorized specifically to SAH, subarachnoid hemorrhage. IVH can occur with an ICH. It can occur with a subarachnoid hemorrhage. It can occur with any bleeding that happens in the brain. The point being that the presence of intraventricular hemorrhage does have a worsening effect on mortality. So it can lead to hydrocephalus, but in general, patients with a subarach, especially if it's a severe subarach, are going to get a drain so that we can monitor their ICP, we can drain off as needed, and we can kind of keep tabs on how things are going. Now, as far as symptomatic presentation, these patients have what is often described as the worst headache of their life. Sometimes you'll see this as WHOL. It is an actual medical acronym. It can start at that, or it can also be described as a thunderclap headache, and can go as far as having focal stroke-like symptoms and or the patient falling into a coma if it is severe enough. One of the primary complicating factors in subarachnoid hemorrhage is vasospasm. The leading theory as to why this occurs is that the blood breakdown within that subarachnoid space sits on the vessels and begins to irritate the vessels and can cause them to spasm shut. This can lead to infarction if it is not treated. So you have to very closely monitor these patients. Your vasospasm window is up to 21 days and typically peaks around days 7 to 10 or 4 to 10, depending on which one you look at. These patients are started on a medication called nimodipine, which is a prophylactic against vasospasm. And they are going to be on it for the full 21 days. You're going to get 60 milligrams every 4 hours or 30 milligrams every 2 hours around the clock for 21 days. You're also going to get transcranial Dopplers as well to make sure that these patients aren't having spasm. On this slide, you can see a picture down here in the bottom right of a intraventricular hemorrhage that extends down into the basilar cisterns here. So this is all blood. And then if you're looking out in the periphery, you see these little white projections. This is all subarachnoid hemorrhage, and you can tell by the CT, or I can tell by the CT, that this is a very severe subarachnoid hemorrhage because you have what you call a holohemispheric presentation, meaning that it's covering the entirety of a hemisphere all the way around. What medication did you say that would be on? Oh, so the medication is nimodipine. Nimodipine. All right, so here's a little outline of cerebral aneurysms, and over here in this little pictogram, you can see kind of what this looks like, and you can see you can see a little bit better on this bottom right-hand side, but this occurs typically at the bifurcation of the vessels. Now, over here on the left side, you can see two pictures from a cerebral angiogram, and it appears to be a right ICA vessel. You can see the MCA distribution fanning out here. You have the superior distribution and the inferior distribution. You also can see your ACAs as well. So on this bottom, you can actually see signs of vasospasm down here in the MCA and ACA. Now, your patient can be in vasospasm and have no symptoms. Your patient can be in severe vasospasm and have no symptoms. But that doesn't mean that you don't still assess them frequently, because that can change, and change really fast. You want to keep these patients euvolemic. Traditionally, we've used triple H therapy, which I'm not even going to get into because we don't use it anymore. But typically we want to keep their INO status normal. If they begin to go through something like diabetes insipidus or cerebral salt wasting, in which they begin to diurese heavily, we want to keep them net neutral. So we want to replace their fluid status as it comes out. If they can drink, that's great. If not, you may need to give them a lot of extra fluid. So subarachnoid hemorrhages are almost always due to bleeding aneurysms, but can be due to trauma. If a patient has a traumatic subarachnoid hemorrhage, it's typically much smaller and much less deadly. Aneurysms, we talked about the causes of aneurysms already, but it says here that they're caused by atherosclerosis, which it can happen. But one thing I do want to mention is that aneurysms can become very atherosclerotic, which makes them very difficult to treat. In these patients, let's see if I can find the slide here. Oh, neck pain. Don't forget neck pain. Nuchal rigidity. All right. We'll table that and come back to it. So let's jump down to the nursing interventions for these patients. Like I said, we want to keep them euvolemic. Dark room, but that may not be necessary. It's more if your patient is experiencing some form of photophobia. Sunglasses work well. Honestly, you want to try to eliminate any day-night alteration as much as possible. These patients, given that they're going to spend a lot of time in the ICU and be woken up around the clock for many, many days, you want to try and keep their sense of day and night intact. It says no emotionally stimulating visitors, which is intensely hard to accomplish, but I agree with that wholeheartedly. These patients don't need any added stress. You're going to do blood pressure control judiciously. You're typically going to monitor these patients every hour at minimum for neuro changes, and they're almost always going to spend 21 days in the ICU. making sure they're oxygenating well, making sure their airway's patent, and keeping an eye for any focal symptoms that may indicate that delayed cerebral ischemia or vasospasm has occurred. Do we need 5 minutes? If you want a break, you better speak up now, or I'm going to keep talking. All right, Chelsea, go warm up your coffee. 5 minutes.